Thank you very much for the kind invitation to present today at your annual meeting. It's my distinct pleasure to be here with you, and I apologize that I'm unable to join you in person. I was asked today to provide updates from both the Tandem and the EBMT meeting, focusing particularly on the management of ruxolitinib-refractory graft versus host disease. And over the next 20 minutes or so, we'll go through highlights from both the Tandem, EBMT, and one or two highlights from ASH. These are my disclosures. So over the last few years, not only have we come up with a firm definition of steroid refractory acute GVHD, but we now have formal definitions of ruxolitinib refractory acute GVHD as well. While they're a little less stringent because they provide day ranges rather than strict day definitions, they are in fact useful so we can enroll our patients on clinical trials and pretend to speak at least the same language. Now, why is ruxolitinib refractory GVHD an important concept? Well, on the acute GVHD side, it's relevant for the following three reasons. First of all, we learned from the REACH2 trial that the durable response rate to ruxolitinib in acute GVHD was under 40%. And therefore, we need agents that are better and provide a higher response rate. We also know that the response rate is very dependent on the severity of acute graft versus host disease. And for grade 3-4 disease, the response rate is only 25% by day 28. And then finally, ruxolitinib, in comparison to best available care, provides no survival advantage from a non-relapse mortality point of view. And therefore, we certainly need agents that will move the needle and increase survival. So I'm going to start by reviewing a novel class of agents called the GLP-2 drugs. These are compounds that are actually approved in the United States for treatment of short gut syndrome because they stimulate the proliferation, growth, and health of intestinal epithelium, providing a larger resorptive surface in the GI tract. These GLP-2 analogs have a number of other anabolic type functions. They keep the intestinal epithelium healthy. They stimulate the Paneth cells to provide chemicals that promote the growth and maintenance of a healthy microbiome. And they have a number of other important homeostatic functions in the GI tract. Now, in a GVHD model, on the left-hand side, we see that mice administered a GLP-2 analog, such as teglutide, have increased survival compared to vehicle controls in a GVHD model. And on the right-hand side, we see that this can actually be quantified with a reduction in intestinal pathology scores for both the small and large intestine, as well as for the liver. At ASH last year, Robert Zeisser presented the first findings of a study examining apraglutide, another member of the GLP-2 family, in a multi-center phase 2 prospective study for steroid refractory GI-GVHD, where this drug was given with ruxolitinib. This is the format of that study. All subjects were given steroids and ruxolitinib, and then 3 different doses of apraglutide, either based on weight or fixed dose. The overall response rate in this study was about 55%, with nice durability through day 56 and 91. The CR rate was only 29%, and that's unfortunate because in steroid refractory acute GI-GVHD, it's really all about complete responses that matter. Overall survival was pretty good, a little over 50% for patients with steroid refractory acute GVHD, But in this small cohort, it's really hard to interpret whether these results were meaningful or not. And for that reason, at the Presidential Symposium at EBMT, Dr. Zeisser presented a retrospective look comparing the 31 subjects on the Stargaze trial to 31 subjects who were in the MAGIC consortium database. And these subjects were first matched based on age, the degree and grade of graft versus host disease, and their overall severity. And you can see here that almost 2/3 of the patients had lower GI stage 3 or 4 disease at the time of enrollment into this cohort. When we look at a comparison of response rates at day 28, day 56, and day 91, we see that the response rates for the Stargaze patients were higher than those of the patients in the MAGIC control cohort. Now, we aren't sure that these are necessarily comparable patients, and the numbers are very small, with only 31 patients in both arms. However, there appears to be enough of a signal that this is interesting and is going to be tested in a proper prospective trial moving forward. Additionally, there was data from this comparison that suggested that non-relapse mortality was slightly better with patients who received apraglutide, although overall survival at 6 months really was no different. There was a slight improvement at 12 months. So again, promising, and certainly needs to be tested in a prospective fashion. Now, also coming from the Zeisser lab is data that suggests that ROCK inhibition might actually be relevant in acute graft versus host disease. Of course, we're all familiar with belumosudil as being the ROCK inhibitor licensed for the use in chronic GVHD. But this volcanoes plot on the left demonstrates that ROCK1 signaling is upregulated in patients who have steroid refractory acute GVHD. And at the tandem plenary this year, further data was shown on the utility of ROCK1 inhibition in acute graft versus host disease. So in this set of experiments, it was demonstrated that ROCK1 inhibition was associated with improvement in overall survival in a GVHD murine model. And there was some degree of the ability to quantitate this. We saw less CD8 T cell proliferation in the presence of a ROCK inhibitor associated with this improvement in survival. And so stay tuned. There will be formal ROCK1 testing in acute graft versus host disease. Now, I'm going to rapidly switch over to chronic GVHD because this is where there's a little more activity. So very briefly, we know that there are now 4 agents that are approved in chronic GVHD. We have ibrutinib, which was the first drug approved in second line, belumosudil, which was approved next for the management in third line and beyond. Ruxolitinib was then approved in second line, and then there's axatilimab, but we'll come back to those 2 compounds. So speaking a little more on belumosudil, at EBMT, there was further data on the use of ruxolitinib in the real world. So the Spanish group presented a poster on the use of belumosudil in second line and beyond, third line and beyond. And then finally, the Canadian group demonstrated quality of life improvements using the modified Lee symptom score. And these were posters that were both presented very recently at the EBMT meeting. Also at the EBMT meeting was an important real-world study called the ROCK-REAL trial. Now, this was a study that was done comparing patients using chart reviews. The goal was to compare the outcomes of belumosudil to best available care when given according to label. And the best available care agents are shown here on the bottom left. The statistical analysis here was something called the targeted maximal likelihood estimation, or TMLE, and that's a new statistical methodology to many of us, and was demonstrated to be the right way to do this analysis. Now, the patients were roughly similar at the time of their trial entry into this ROC-REAL study. I will note that the patients who received belumosudil had a much higher rate of having prior exposure to ruxolitinib. The best available therapy patients um, extended farther back in time, well before the use of ruxolitinib was common in graft versus host disease. And that is a major criticism of this analysis. Overall, at 6 months, the best available response rate here was close to 40% for patients receiving belumosudil and only 27% for best available care. Again, the availability of the novel agents to the best available care arm was somewhat limited, which does reduce the validity of this analysis. Failure-free survival was somewhat higher in the belumosudil arm, again with the same caveats. And in terms of safety, overall, belumosudil was slightly safer than the best available therapy arm, but about a third of patients overall had at least one adverse event. So if belumosudil is a good compound in chronic graft versus host disease, now we're going to start to see follow-on compounds. And the most important one that we saw was a study of TDI-01, which was studied in chronic graft versus host disease. Now, TDI-01 is in fact just another ROC2 inhibitor, which has much higher affinity for the ROC2 enzyme. And so it's a more potent inhibitor of ROC2. The study was a phase 1b dose escalation trial with patients being tested at the 200 milligram once daily and 400 milligram once daily dose levels. The trial was very similar in design to the Rockstar study. Here are the patients. Overall, 60 subjects were enrolled, of whom about 3/4 had previously received ruxolitinib. They had a median of 3 lines of therapy, but could have had as few as 1 line of therapy prior to their enrollment. So these patients are not exactly the same as those enrolled on Rockstar, because those patients had at least 2 lines of therapy in the past. Here are the overall response rates. You can see that the best overall response rate at the 400 milligram daily dose was 86%. It was 68% in the 200 milligram once a day dose. And the overall response rate at week 24 was about half of the subjects overall. And so in this experience, it appeared that the 400 milligram dose was slightly better than the 200 milligram dose. This is the failure-free survival curve, again demonstrating an improvement in failure-free survival at the 400 milligram once daily dose. And then, of course, the organ-specific analyses were performed, and these demonstrated that there were nice responses across all the organs, and just as in that appeared to benefit more or less from TDI-01. So after belumosudil, as I mentioned before, we have ruxolitinib, which in fact was the third agent approved in chronic graft versus host disease. And then finally, we had axatilimab approved in November of 2024, and we've now started treating our first patients with axatilimab using commercial drug supply. So for those of you who are not terribly familiar with axatilimab, this is a monoclonal antibody against the monocyte macrophage receptor CSF1R. The drug was approved on the basis of the Agave 201 study. And that trial design is shown here on the top right. At EBMT, An update to the Wolf analysis was presented, and the Wolf analysis is shown here on the bottom left, with an overall response rate of about 74% in the 0.3 milligram per kilo every other week dose group. And the important update that was demonstrated at the EBMT meeting in abstract B040 was the time to response based on NIH criteria. And I think this was really quite telling, because what it demonstrated to us was that almost 75% of subjects who are going to respond ultimately to this compound do so by day 56. Interpreted another way, if patients have not had a response by day 56, they are not terribly likely to do so moving forward. Of course, the curves go up to 100% because these are analyses only of the responders. So again, very brisk responses by day 56. There were several posters on axatilimab at the EBMT meeting. The first shown here was an analysis that didn't terribly show us that clinician-reported responses correlated with NIH-reported responses, which was a little bit disappointing. The next poster that was presented on axatilimab looked at prior lines of therapy as a way to predict which patients would respond better. And in fact, here, the analysis demonstrated that patients who had most recently received ruxolitinib had a slightly better response rate. That's a little bit hard to understand, and I think is somewhat a little bit difficult to interpret or to incorporate into clinical practice. Now, axatilimab, as I mentioned, is an intravenous monoclonal antibody. And of course, from a convenience point of view, something that was oral would be much better. And so at ASH last year, an oral CSF1 receptor antagonist was presented, and this is pimicotinib. And this study was done very much in the style of Rockstar and then the Agave 201 study. And this study demonstrated very nice responses in patients who had steroid refractory and ruxolitinib refractory chronic GVHD. And again, the investigators here wanted to highlight the fact that there was improvement in subjects who had pulmonary involvement. A second oral compound, vimseltinib, is currently being tested in a phase 1 and phase 2 dose escalation and dose expansion study here in North America, and we hope to have results of that in the coming year. So, what to do in ruxolitinib refractory chronic graft versus host disease? Well, if your patients have not responded to ruxolitinib, you have 3 FDA-approved choices. But in fact, what many of us are doing these days is simply adding the novel agents to ruxolitinib rather than replacing the ruxolitinib with a novel agent. And so we are learning now more about combinatorial therapy. And I'm going to present to you a few abstracts that were presented in 24 and then again in 25 at the Tandem meeting. And so this is real world evidence from Memorial Sloan Kettering, where 66 subjects treated with ruxolitinib demonstrated an overall response rate of about 60% or so when belumosudil was added on to ruxolitinib as opposed to replaced. Very importantly, the rates of toxicity in this study were very low. And then a study by the Israeli group demonstrated very similar findings. This is 32 subjects treated, both adults and pediatrics, of whom the majority had ruxolitinib. And the best overall response rate to the addition of belumosudil to ruxolitinib was about 50%, with subjects who had responses having better outcomes in the long term. Specifically in pediatrics, there was one abstract presented at Tandem that looked at 8 children aged 12 to 20, and 7 of 8 of these children improved nicely, including the ability to come off immunosuppression entirely. Now, if JAK inhibitors are good and ROCK inhibitors are good, what about the combination of the two in one tablet rather than giving them combination ruxolitinib and belumosudil? And the first analysis such as this was presented at ASH last year, and this is roviticitinib, again a combined ROCK-JAK inhibitor. Here are the baseline characteristics of the 44 subjects who were treated on this phase 2 trial. You'll note that a significant number, in fact, had not previously been exposed to ruxolitinib. And so when you see the response rate of 91%, that's not surprising overall, because some of these are patients that are ruxolitinib naive. So you will be seeing more follow-on analyses and more follow-on compounds that have multi-kinase inhibitory activity. And then the last abstract I want to present was at this year's Tandem, and this is data from Kreitmeyer, who was kind enough to share his slides with me. And this was for patients with steroid refractory chronic GVHD using in vitro expanded donor Treg cells. And this is the schema of the trial. So this was a 3+3 dose escalation study. And in fact, there were no DLTs. And so they went on to treat 3 dose levels of subjects. And in fact, the expansion phase was at dose level number 3. And that was where 15 subjects were eventually treated. The response rates are shown here on the left-hand side. The overall response rate at 3 months was modest. 6 of 20 subjects responded, and the specific organ distribution is shown below, with failure-free survival being a median of about 6 months or so. The reason for failure in this analysis was almost all related to the initiation of a new immunosuppressive therapy. Multiple groups have tested this approach. This is another real-world example that we can do in vitro expansion of regulatory T cells, and more work certainly needs to be done on the topic. So just to conclude, ruxolitinib-refractory acute and chronic GVHD still remains a critical issue for our patients. Unfortunately, what's nice is that we have potent and orally available agents now. Whether those agents are absorbed in GI diseases is unclear. But what I think will be important is that we are going to start to deliver the most potent combinatorial therapy early in patients' disease courses to prevent ruxolitinib refractoriness. And then, of course, as we roll out novel GVHD prophylaxis regimens, hopefully the overall incidence of chronic and acute GVHD will go down in the future. With that, I'm going to stop. My email address is here on the bottom. For anyone who might have questions, I do apologize for not being able to be with you live or in person today. And again, I'd like to thank you for your attention. And if there are any questions or follow-up, please don't hesitate to reach out. Thank you.